Now we will be studying about the neoplastic proliferation of WBC. What is it? Neoplastic proliferation of WBCs means it refers to the clonal monoclonal disorders of your hematopoietic stem cells. These orders range from acute leukemia to chronic leukemias. The disease either can be acute or either it can be chronic. Now, coming to the normal hematopoiesis, there is myeloid lineage. And there is lymphoid lineage. In the myeloid, you need to know that there will be granulocytes, monocytes, RBCs and platelets. In the lymphoid lineage, there will be B cells, T cells and NK cells. Now, coming on to a broader classification. First one is your myeloid neoplasm. In myeloid neoplasm, you have three. Okay. In the myeloid one, I need to remember three. What are they? AML, that is your acute myeloid leukemia. Then you have MDS, that is your myelodystrophic syndrome, and MPN, that is your myeloproliferative neoplasm. Now, coming on to the acute myeloid leukemia. In acute myeloid leukemia, it is a neoplastic proliferation of your immature myeloid blast. In the MDS, it is ineffective, cytokines will be there, and there is a risk of AML. That is acute myeloid leukemia. See guys, we will study them in details also, so don't worry, okay? Then you have your myeloproliferative neoplasm. When there is excess production of your mature myeloid cells, then this syndrome will occur. Next you have is your lymphoid neoplasm. Now what happens in lymphoid neoplasm? First thing first, in the lymphoid neoplasm, I need to remember two. Either it can be acute or either it can be peripheral. Now, in the acute one, I have ALL. In the peripheral one, I have two types, B and the C. B cells and the T cells. T cells. Okay. Now, in the B cells, I have CLL, mainly follicular lymphoma and Burkitt's lymphoma. In the T cells, I have adult T leukemia and your mycosis fungoides. Coming on to the pathogenesis, what happens first? First thing first, there will be genetic abnormalities. Like guys, see, on the basis of genetic abnormalities, like on the basis of chromosomal translocation, we will be able to diagnose. Like when there is CML, so there will be translocation 922 and BCR-ABL. For acute promyelotic leukemia, there will be T1517. For Burkitt's lymphoma, there will be T814. T8 and 14. So see, 8 is looking like B. Okay, somehow if you try to draw a B also, it will be like 8. So 8 is looking like B. So B for B, Burkitt's, you have 8. T814 for Burkitt's, T1418 for your follicular lymphoma. Then what are the epigenetic changes you have? In the epigenetic changes, you have altered methylation and histone modification, which leads to your disrupted differentiation. Microenvironmental factors. What are the microenvironmental factors you have? You have cytokines, growth factors and bone marrow supports that are there. In the viral etiology, you need to remember EBV is for Burkitt's lymphoma, Hodgkin's lymphoma and post-transplant lymphoproliferative diseases. Then you have HTLV1 for your adult T cells and HHV8 for your primary effusion lymphoma. Coming on to the morphology and the cytological features in the peripheral blood smear. See, in the peripheral blood smear, I'll show you also. I have the images also. I'll show you. Okay. Remember, smudge cells are seen in your CLL. Orsrods are seen in your AML, and there will be presence of blast. Okay. In the bone marrow, there will be hypercellular with replacement by neoplastic cell. There will be suppression of normal hematopoiesis. In the lymph nodes and other organs, I am able to see there will be diffuse or nodular infiltrates and organomegaly will be there. This much should be clear to you. What are the clinical features? In anemia, there will be mechanism is there will be marrow replacement, which will cause decrease in the RBC production, as a result of which it is seen in all the leukemias. Second thing, there will be infection, which will cause the mechanism it will cause neutropenia, and it is seen in all the leukemias. In the bleeding one, there will be thrombocytopenia. It is seen in acute leukemia. Bone pain is seen in marrow expansion and acute leukemia. Lymphadenopathy is seen in infiltrates and chronic leukemias. What are the diagnostic investigation? First thing, I have to order a peripheral blood examination. In the morphology, I am able to see blast and dysplastic changes. In the cytochemical stains, I am able to, what are the cytochemical stains I will take into consideration? Sudan black, I am able to see the myeloid lineage. 𝗃𝗃, that is, I have told you in the GIT, the 𝗵𝗵𝗵𝗃 disease, 𝗃𝗃, right? It is for your lymphoid blast and MPO is for your myeloid cells. Then you have flow cytometry. In the flow cytometry, remember the three markers, B cells, T cells and myeloid markers. Then you have cytogenetic and your molecular studies, like you will do the karyotyping, FISH, PCR and detect the specific translocation. See guys, this is the major entity summary that I have made. Here only I have given you all the images. First thing, image of AML. Cell type is AML. So M have myeloid blast. There will be 𝗲𝗏. See, this one is your 𝗲𝗏. It will be MPO positive. Translocation T15, 17 and T821. ALL, there will be lymphoid blast. TD, T positive and T1221 translocation and T922 translocation. CML, mature granulocytes, there will be basophilia and splenomegaly. T922 and BCR-ABL. In the CLL SSL, there will be mature B cell, smudge cell. See this figure. You are able to see that all the cells are properly placed, plus this cell is smudged. Okay, so it is a smudge cell. It is due to the deletion of your 13q. Burkitt's lymphoma B cell, there will be 𝗲𝗵𝗵𝗃. This one is your 𝗲𝗵𝗃𝗃. Translocation is 814 and there will be a mutation in the MYC gene. Follicular lymphoma B cells, there will be nodular pattern and translocation in T1418 and BCL2. Diffuse large B cell lymphoma, there will be B cells and large atypical cells. Okay. Adult T cells leukemia, cell type is T cells. There will be clover leaf nuclei. Okay. What are the complications? In the complications, there will be bone marrow failure. Then there will be disseminated infection, tumor lysis syndrome and transformation, like there can be blast crisis. Then you have the secondary malignancies can be there. What are the treatment for the acute leukemias? I will give chemotherapy for my patient, bone marrow transplantation. For the chronic leukemias, I have to give the targeted therapies, then lymphomas, combination therapy, monoclonal antibodies and radiation. For the supportive care, I have to give transfusion, antibiotics and growth factors. What are the prognostic factors? See, prognostic factors are your age and performance status. Then you have the cytogenetic abnormalities, response to your initial therapy and disease stage. These things you need to check. So I think if you read this summary, it will be sufficient for you to write in your exams. If you have any sort of doubt, please don't hesitate. Please feel free to ask me. Please feel free to DM me. Thank you so much.